Subramanian to introduce our speakers today.
Thank you. Hi, everyone. I am so excited to have this group on today. We're really bringing you the most exciting people on the planet, it seems like to me. And Mike Oken has been really generous with providing names and being the cheerleader for all these fabulous people that he's trained and who he works with. And so just really excited to promote this new book called Living with Parkinson's Disease. And the authors here, we have two of them. So we have Irene Malaty, who's at the University of Florida. She's an associate professor there, and really just a practical, exciting sort of approach to Parkinson's disease that we'll talk about from her. And then also Wissam Deeb, who I got to catch up with a little bit, who was Mike Oken's fellow and is now at the University of Massachusetts. And they've worked really diligently on bringing some, just the sort of neurology pearls, as we call them, when we teach our residents. We sort of talk about these pearls, which are really just these nuggets of just great information that we pass on from doctor to trainee, doctor to patient, and patients to patients, and providers to patients. And so they have, as you know, because we've seen them before, this amazing multidisciplinary team. We had Nicole on, who is their speech pathologist, and Mike's been on a couple of times. And so we've just been really excited to get to know their team. It's such a great place to train. And Mike is just a leader in education. He's the chairman there and a patient advocate. So it brings a lot of different worlds together. So without further ado, maybe I could ask you each a little bit about your journey, what led you to work with Mike, and kind of why you decided to be part of this book. So maybe we'll start with you, Irene.
Sure. So I think I just always liked the brain in general. So I became a neurologist because I really enjoyed trying to figure out why people behave the way they do and think and act and function. And so I got excited about the brain and became a neurologist. I had an uncle who had Parkinson's disease that I especially loved. And I'm not sure if that sort of subconsciously drove me, or I just really enjoyed the people that I got to work with, and I got to enjoy helping try to make quality of life better. And so that's what kind of drew me to Parkinson's. And then in terms of the book, we know that the world is really flooded with information. I mean, I could try to buy a toaster and spend 30 minutes on the internet reading reviews and different things, and imagine trying to navigate your healthcare. There's so much information, good and bad, and you can really get led astray believing things that people post that may be inaccurate or may be really specific to one person's experience. And so we really felt inclined to try to put out some solid information that was user-friendly and accurate and safe. And so Michael asked Wissam and I if we wanted to help write a cookbook for Parkinson's. He literally told us it was going to be a cookbook for Parkinson's. And that's how this came up. This is the cookbook. It's called Living with Parkinson's Disease. And so the three of us worked together, and chapter by chapter, we also had a beautiful human being whose wife lived with Parkinson's disease, who donated his photography, and he took pictures of people with Parkinson's disease to put inside of our book, just to make sure to bring some of the personality in. And so that's kind of how the process came about.
I love that. So it's a cookbook for Parkinson's disease. We gotta market it as such, because I think it's really lacking. And so there's sort of, sounds like recipes and step-by-step sort of ways to improve your health. And everyone knows this already, but I have a very holistic way of thinking about healthcare. And I think you guys have done a really good job of not just talking about the pills or the surgeries, but sort of a lifestyle approach. If you guys are going to write round two, I'd love to contribute a little bit more on yoga and mindfulness. But outside of those two, great. I think you've covered it all. So I'm really, so much on exercise. The therapists that work with us, I know Nicole said that she contributed some things as well. So it just sounds like a really rich and practical book. So that's exciting. So Wissam, you're not off the hook. I'm going to ask you the same thing.
I was like, I'm going to escape.
Tell us a little bit about your journey and what made you become a neurologist and start to be interested in Parkinson's and leading to the book writing.
Yeah, so I'm a very similar journey. I'm always was a little bit nerdy, and then neurology is one of these nerdy fields. I like to look into details and try to come up with, deduce certain patterns. I like to look at puzzles and try to fix them. That's something that excites me. And then neurology is at that cusp, and especially movement disorders. And I also I really enjoy being with my patients and then seeing their journey with their diseases, trying to help them through the process. And Parkinson disease and other movement disorders provide that opportunity that you can be there for the person. You can engage in research, you can engage in education, you can engage with them and their family. And so that was what drew me to movement. And then Dr. Oken is very well known in the field of Parkinson and movement disorders, so it was not very hard decision for me to try to make it to be a fellow there at the University of Florida. So that's how I ended up there. And then for the book, it's very similar. Just as Dr. Malaty said, there's a lot of information, but sometimes it's very hard to find the information you want in a very concise, easy to find way. So that was the major impetus to do the book, is to do this cookbook style where you have the ingredients, like you can directly look, okay, what are the symptoms of speech problems? Okay, this is where I can find them. Okay, this is another section about the methods, or like how to cook them or how to get them better effectively. And so it really follows a cookbook in terms of it's very easy to read, very easy to find, and has some stories that connect with like certain patients' experiences that might be easier to connect to than just like a more abstract discussion. So that was the major impetus for the book. And we worked all together with the book. As you mentioned, a lot of our colleagues in rehab and nutrition have helped in contributing and then giving their experience too, which many of us as doctors might not experience or not have the same expertise about these difficult intricacies that we learn from our patients and then also learn from each other. So some of these pearls also are coming from this collaborative interdisciplinary approach in managing people with Parkinson's.
Absolutely. Well, that's really exciting. And I know that you wanted to highlight some specific non-motor issues this time around. Maybe I know that you prepared some slides. Maybe we could start with those, and then we can kind of sort of meander into possibly some questions and a discussion a little bit after that. So.
That sounds good. So what we wanted to do was to just sort of share the top 10 non-motor symptoms. So, most people know about Parkinson's disease as something that affects your walking or causes tremors. And people who live with Parkinson's disease recognize that that's really just the very superficial and externally apparent part of Parkinson's, but really the internal experience involves a lot of additional things. So we wanted to just touch on 10 non-motor symptoms and the tips that can help manage those. So Dr. Deeb will kind of start with the first 5, and then I'll pick up with the second 5. And then if people have questions, we'll be happy to answer those. So Dr. Deeb, I can advance. I'm going to go ahead and share these slides, and everybody can let me know that it works. All right.
It works.
Can everybody see the slides now?
Mm-hmm.
Okay, great. So Dr. Deeb, you just let me know when you want me to click.
Okay. Let's move.
All right, we'll go ahead.
Yeah, so as Dr. Malaty was saying, so whenever we think of Parkinson's disease, usually the first idea that comes to mind is a person who has tremors or a person who has some slowness or walking problems. But all of you know that, and they've all seen this iceberg picture where like you have this at the tip of the iceberg, you have the tremors, but a lot of the features that are there and then also have a major impact on the quality of life of people living with Parkinson are what we call these non-motor symptoms. So the term non-motor symptoms is like a very large term that means anything that you cannot see involving a muscle. And so it can be anything from thinking, speaking, swallowing, stomach issues, skin issues. So it's a huge number of things. And then, as you know, Parkinson's disease can involve a lot of components in the body. And then it's very important to discuss these, to know about them and discuss them with your healthcare professional. And so in the book, we didn't only focus on the motor symptoms. There's one chapter really only on the motor symptoms, and the rest of the chapters are mainly on these non-motor symptoms. So we can go ahead. Next. All right, so what we're going to try to highlight here are three objectives. The major ones are that we want to highlight with you 10 very common non-motor symptoms in Parkinson's disease, and then understand their impact in people with Parkinson, and also share with you some pearls. All of these pearls are from the book about how to manage these non-motor symptoms. That these pearls are how to manage it without a doctor's help, without medications, most of them, or also how to understand when to approach them and when to use the certain medications that you would need. So these are the ones we're going to discuss. So there is one called sialuria, which is drooling. Then we're going to go down into the intestinal tract and speak about constipation. Going to speak about urine symptoms. Going to speak about orthostatic hypotension, which is dizziness when standing up or low blood pressure. What about pain? I'm pretty sure a lot of you have heard that pain and Parkinson's disease are a little bit associated, so we're going to speak about that. Apathy, which is decreased motivation, depression or sadness, memory problems, hallucinations, and also sleep problems. So you can see this is like some of the symptoms. These are the most common and the most, usually the symptoms that have the most impact on quality of life. And then we're going to go through these very briefly in about each one of those symptoms. So first of all, this drooling issue, or the sialuria. So this figure here shows that the types of glands that produce saliva in the mouth. There are 3 glands, and the ones that are most important are the parotid gland, that's the bigger one, and then the other one is submandibular glands. Both of those glands produce around 90% of a person's saliva. So why do we care about saliva production in people with Parkinson's disease? People with Parkinson have a higher tendency of drooling. And drooling can happen for multiple reasons. You can have drooling because you're producing too much saliva, or you can have it because you're not absorbing or taking the saliva down and swallowing it. And that's this second part is what we think happens in people with Parkinson. It's not that they produce more saliva. Some people might produce even less saliva, but they're not swallowing it appropriately or frequently. And that's the same thing because generally the movements are slower in people with Parkinson. So the swallowing movements are slower and less frequent. And then in that case, the saliva pulls in. And also the other thing is that people with Parkinson usually have a stooped posture. So their head and mouth are usually a little bit forward. So it makes it easier by gravity for the saliva to come out. And as you can imagine, this can be quite embarrassing socially if you're out at dinner and then there's drooling events. So it can be quite distressing. And in addition to this, it can give some inflammation in the mouth and inflammation in the lips that can also cause infections. So it is usually something that we want to follow and then manage. So what can you do if you have some drooling? And there are different levels of drooling. So some of the things you can consider are one of the easiest things is possibly, especially if you're at dinner, for example, is to always or like regularly sip on fluid. So if you have like a little bit of water, a little bit of juice, a drink, sip on that very slowly. That will stimulate your body to swallow the saliva more frequently, and then you have lower tendency. So this is usually a good trick if you're in a dinner party. Now, COVID times, we're not having too many dinner parties, but at some point we're going to do this, and then that could be a good tip to help with this. The other thing is sucking on a hard candy or chewing gum. And then in this case, so let's say you're doing an activity that's not very social. One person here mentioned in the chat that they might drool when they're playing guitar. So this would be a good time, for example, to have a chewing gum or a candy. We recommend sugar-free so that you don't develop tooth decay, but effectively that will have the same principle as sipping on fluids. It will stimulate your body or your mouth to swallow, and then you will have less saliva pooling in the mouth. Now, if these are like the simple home remedies to help with drooling, if these are not helpful, then in that case, you and your doctor would decide on certain types of medicines that you can consider. Some of those are local medicines that will be drops. These are eye drops, usually called atropine drops, that can be put on the tongue and they can dry the secretions. And there are some medicines by mouth that can be taken as a pill And also some of them are also patches. So this is what we mentioned here: anticholinergic medications, glycopyrrolate, and scopolamine. And then also there is a use of botulinum toxin, or what you would then usually call Botox. So Botox here can be used to also dry up the secretions and decrease the drooling in people. And so usually that's something, of course, that you and your doctor would discuss about the pluses and minuses, but of doing any of those approaches. But this is, for example, some tips that you can consider for drooling. Now, what about constipation? So constipation is not pleasant, and it's very, very common in people with Parkinson's disease. And it is defined by a low number of bowel movements. The frequency of bowel movements are low, or is low, and then also the stools are hard. But also it comes with bloating, it comes with excess gas, it comes with discomfort, but also it can worsen the symptoms of Parkinson in general. So you can have worsening of the motor symptoms. It can also disrupt the absorption of the pills like carbidopa, levodopa. So it's very important to be aware of constipation and manage constipation to avoid these effects. And then in Parkinson's disease, the constipation can be for multiple reasons. Parkinson's disease itself can give constipation because it slows down the intestines and can even slow down the stomach. But also, in addition to this, people with Parkinson's disease tend not to exercise as much, and lack of exercise or decrease in exercise can also worsen constipation. They might have urine control issues, and we're going to speak about those. And then in that case, they might restrict how much liquids or fluids they're using. And then that can also cause more constipation. They might feel that they get full very quickly, and that's because of the slowness and movements of the gut. And in that case, they might not have enough fiber or amount of food in their diet, and they can cause constipation. Or they might be given some medicines, like we spoke before for the drooling. Some of the medicines that are helpful for the drooling can cause constipation as a side effect. So that could be also sometimes medication induced. So there are multiple reasons, and it's very important that you're aware with you and your doctor about what is causing constipation for you, and try to address that from multiple levels and not focus on it. So it's okay, there's constipation, I need to take a laxative. There could be multiple things that you can consider before that stage. So some of the things we share usually, we can move, sorry. Some of the shares we share usually with our patients is this natural constipation formula or strategy. This was refined by a physician assistant at University of Florida. Her name is Janet Romerol. And it works. Not everybody, of course, benefits from it, but a good proportion benefits. So it's very easy. You would mix a cup of unprocessed wheat bran with half a cup of applesauce and half a cup of prune juice. You mix these and then put them in the fridge. And then you would use 1 to 2 spoons every day. And that usually will give you enough fiber as well as a little bit of a laxative effect from the prunes to help with bowel movements. This concoction would last a week safely in the fridge. So you need to make it again every week. And then like anything else, whenever you start it, it's very good to start it low and slow because of all the fiber that you have there. If you start too much, if you start initially by like 3 spoons a day, then you would most likely have bloating and gas, and then you will feel miserable for a bit. Usually the effect of it you would see within a week. And then most people, if they have some bloating or gas because they're not used to this much amount of fiber in their diet, that will stabilize within a month as the bacteria and the intestines catch up. So this is like one recipe that can be helpful. Of course, we would share usually also information about the role of exercise, the role of hydration, the role of how much fiber you need to have in your diet, and of course the over-the-counter remedies that you can find, certain types of foods that are high in fat that can also help with loosening the stools. So there are multiple things that we can consider before trying to use prescription medications to manage constipation. All right. So urine symptoms, these are very, very frequent. They can even start before people have their tremors or their stiffness. And there are multiple forms of them in Parkinson's disease. So you can have frequency, which is like going to the bathroom many times during the day, or also frequency at night, where you wake up multiple times. And that can be very disruptive. Your sleep might not be as good. Your bed partner's sleep might not be as good, and nobody's going to be happy after that. Also, it can be socially limiting. You might not want to go to certain places because you're, okay, where's the bathroom? How can I make it? Am I going to make it on time? And also there can be incontinence, which is not having some accidents. So because of this, we usually pay attention to this type of symptom because of its significant impact on quality of life. And because also the other important thing is that many people who have these symptoms try to restrict water intake, which is not very good for multiple reasons, like we spoke, constipation. And later we're going to speak about the orthostatic hypotension, low blood pressure problems. And both of these can get worse if a person is restricting fluid. So can go to next slide, please. So these are some non-medication tips and also non-invasive things that we can consider to manage the urine symptoms. So first, one of the things that we recommend to people who have a lot of frequency at night is to limit how much fluids they're having only after 5 p.m. So that way they will not be dehydrated. They will drink quite well during the day, but after 5 p.m., limit the amount of fluids that they're drinking so that they have less tendency to go to the bathroom at night. Sometimes you would need to use protective briefs or pads, especially if you're going on trips and this is a problem and then you don't want to be restricted, although this can be accepted and not accepted. So it's a good discussion to have. A very important service that you can have in rehab done by physical therapists is pelvic rehabilitation services. These are rehabilitation services that focus on the pelvic muscles and also on the urine symptoms. And they can help with both exercises as well as behavioral changes. So they can give some advice, for example, about doing regular bathroom breaks. Whether you feel you need to go to the bathroom or not, you would go, let's say, every 2 hours. And that way you avoid having like the urgency where you have to run to the bathroom very quickly without any warning. Another thing that's very important if you're going to the bathroom frequently at night is to devise a way that keeps you safe, especially so that you don't fall or trip on something if you're waking up multiple times, and also to make it easier for you to fall back asleep because you're not going to wander the halls and turn on the lights, is to use a bedside urinal, for example, and that way you can urinate at the time and then not have to put yourself at high risk. So these are some approaches that are, of course, non-invasive, non-pill based. Many times, sometimes these don't work by themselves, and then we have to escalate the treatment, but that will be a decision between you and your doctor. Now, what about getting dizzy? This is also another very common symptom in Parkinson, getting dizzy when standing up, usually because of a drop in blood pressure. And we call this orthostatic hypotension. And it's a very common reason people end up in the emergency room because they're feeling dizzy, they're almost going to pass out. In most cases, in people with Parkinson, the reason for this is Parkinson itself causing this low blood pressure. It's very important, of course, to make sure with your doctors that it is not something else, because it could be something else. But the most common reason for this is low blood pressure from Parkinson disease itself. So it's very important to recognize this, that as a symptom. It doesn't always present as dizziness. So don't only focus on that it's dizzy or feeling like you're going to pass out. It can manifest as heaviness on the shoulders, for example, feeling like there's heaviness on the shoulders. Fatigue can be sometimes the only symptom of low blood pressure, or even sleepiness, feeling like you cannot keep focused during the day and very sleepy, can sometimes be because of low blood pressure. So it's very important to check, you and your doctors, or even you at home, to check the blood pressure in these positions, like sitting down and standing up, and see if the blood pressure drops. It's an easy thing if you have a blood pressure machine at home. And then also make sure that you get that checked possibly every once in a while with your doctor in the clinic to see if this is happening or not. So for this, there's a lot of stuff that we can do to help with the low blood pressure. One of the things that works a lot for a lot of people is before you stand up or before you start your day is to have a tall glass of water. So at least 8 ounces of water, preferably cold. And we don't understand exactly what's changing, but it seems that it's activating your nervous system to cause your blood pressure to increase simply by having the water in your stomach. It's important to drink it a little bit on a faster side. Don't sip it in small sips, but like try to drink it quickly. And then usually within 20 minutes, your blood pressure would rise up, and that effect sometimes lasts up to an hour. So it's usually quite good because usually the lowest blood pressure is early in the morning. And so it will be a good way for you to start your day if you're dealing with low blood pressure. Being safe is very important. So try not to jump and change positions very quickly. Give your body time to equilibrate. So it's recommended that you sit on the edge of the bed, not simply stand up very quickly from a lying position, but sit for a few seconds or a few minutes before standing. Also, you can do a little bit of exercise because exercise can pump blood and then cause your blood pressure to increase. So you can, let's say, pump the legs, or for example, bring the knees to the chest a few times in bed before you sit up. Also, it's very important to hydrate, and this is where it can be a bit tricky, because like people with urine problems they have difficulty with hydrating because they're afraid, they don't want to hydrate, they don't want to go to the bathroom. But then in this situation here, we need to hydrate, and this is where discussing with your doctor about how to manage that fluid use, and also possibly with the pelvic rehab person about how to manage these things can be helpful. The other thing that can be very helpful is using compression aids. Now, these come in 2 forms. They can be in form of compression stockings, which most people have either difficulty putting them on and off, or feel that they're very hot and they cannot wear them in the summer. But the other one that can be easy is an abdominal binder. So I'm not sure if you've seen those, but if they're usually given to people after stomach surgeries. They will go across the stomach, and you can change how much pressure by simply like tightening them. And then if you tighten them as much as you can, which usually measures at around 40 centimeters of water of pressure, usually that is quite effective in increasing the blood pressure, and as effective as using a medication like one that would be given for this condition called midodrine. And the advantage of this is that you can take it on and off. So, let's say, you need to stand up and then walk in the next hour, you get the abdominal press, and then you put it on, and then you would use it. And once you sit down, you take it off. So it doesn't have any side effects. The only side effect really is the annoyance of taking it on and off, but also that is an advantage really because you can simply turn it off. Because one of the concerns usually with people with low blood pressure when standing up is that the opposite happens when lying down. Your blood pressure shoots up, and then especially if you're on medications to help the symptom, and then with this abdominal binder, you don't have this concern because you simply take it off, the therapy stops, and then you can keep going. And what about pain? So initially, or let's say many years ago, we didn't think pain was related with Parkinson's, but now we know that the pain is much more common in Parkinson, and people with Parkinson deal with pain very, very frequently. And that could be for many reasons. It could be for reasons like anybody else, like arthritis or nerve pain like sciatica, but it seems that having Parkinson's can make these symptoms even worse. Also, medication fluctuations. So a lot of people, when they take their medicines, they notice what we call an on and an off, a fluctuation. Sometimes the medicine is working, other times it's not. And then with that fluctuation, they might notice a change in their level of pain. Another thing could be dystonia or muscle spasms that can be very, very painful because they feel like cramps. And this can be very painful. So it's very important. We can move ahead. It is very important to find the cause. So what is the reason for this pain? Is it nerve related? Is it bone related or arthritis? Is it related because the medications are not working enough or fluctuating or causing dystonia? So it's very important to know the reason. And that would be something that you and your doctor would try to investigate and find. And sometimes, depending on the reason, you would adjust the medications for it. all of the reasons and associated with pain, usually it's very important to consider physical therapy because that can help with a lot of those symptoms. Sometimes you consider local treatments. And then if you need something by mouth or more chronic for management of pain, it's very important to consider with your doctor the risk and the benefit of taking those medicines, both on the mental state, on the blood pressure state, constipation state. So these pain medicines can be a little bit more tricky in people with Parkinson than people without Parkinson. So it's very important to have a frank discussion about your goals with your doctor. And now we're going to switch gears. Dr. Malaty is going to tell us about the other 5 non-motor symptoms.
Okay, so we're halfway through the 10. I wonder if anybody in the audience has experienced any of the things that we've talked about so far. I'm guessing probably yes. I see some fingers and hands. So we're going to keep moving. The next one that we'd like to talk about is called apathy. And apathy means a loss of motivation or initiative or drive. And one of my patients said it best when he said, my get up and go, got up and went. And so this can be really frustrating, both for people with Parkinson's and the people who live with them, because sometimes it can be disguised by looking like there's no motivation to do therapy, or I don't care to go out. And a spouse might say, you know, you need to do this, you know, the therapist said to do this, and it can be difficult to find the energy and motivation. And it's not only attributable to personality or stubbornness, it's really part of Parkinson's. And so the changes in what we call the frontal lobes of the brain, which is in the front of our brain and wired to the deep areas that are involved in Parkinson's, can actually cause a loss of drive or motivation. And so this can be misinterpreted as not caring about a spouse or a care partner, and it can cause some frustration. But there are some tips to manage apathy. We don't have pills that are really good at overcoming apathy, but we do have strategies. So one of the strategies is to schedule activities independent of the desire to do them. So if you wait to exercise when you feel like it and you say, let me see, I'm not in the mood today, maybe tomorrow, there's a good chance that that keeps getting pushed to the next tomorrow and the next. And we've all experienced this, probably with or without Parkinson's, when it comes to exercise, or maybe it's diet changes and we think, yeah, maybe tomorrow, today's too stressful, I don't have energy today. And there's a fine balance with Parkinson's. We all know you have good days and bad days. And so you do have to have some flexibility. If it's a good day, do more. And if it's a bad day, you can adjust what you do. But it also, when it comes to things that are very healthy, like exercise, that we know is very important for Parkinson's, the best strategy is to say, all right, on Monday, Wednesday, and Friday, we're going to do this. And I'm not going to wait and see if I feel like it, I'm going to schedule it. The other thing is to recognize that you can modify activities. It doesn't have to be all or nothing. So in Florida, many of my patients like to golf. And so it doesn't have to be, I do as many holes as I used to, or I do nothing. Maybe you could do half the course or reduce the amount that you do and still enjoy before you're so exhausted that it, affects you the whole next day. So adjusting how much you do each day, maybe spreading things out into more times, can be helpful. The other thing that can be useful is to have a buddy and encourage each other. And so this is where some of the activities like Parkinson-related exercise groups or boxing or cycling classes can be really helpful, because it's sort of mutual accountability. Everybody looks forward to seeing each other and encourages each other to show up. And so that can be very helpful. Another important thing is to plan your activities around your medication timing, if at all possible. And that will help you optimize your performance and your enjoyment. So most people can recognize that maybe 30 minutes after their medicine or 60 minutes after their medicine, that may be their best time. And maybe that's the time they're most likely able to do certain activities, but maybe 30 minutes before the next dose might be the rough patch. And so it may be useful to try to work in the exercise or the social activities at the time that you know is your best time of day, or when your medicine is most effective. Sometimes you may even work with your doctor to modify your medication schedule to allow you to be doing all the things that are healthy for you emotionally, socially, and physically. So for some people, that might mean an extra half a pill of Cinemed on the days that I do my aerobics. That might be an example. And those are things you can discuss with your physician. The other thing is to make sure you get rest and also maintain a healthy, balanced diet. So if you're overtired or undernourished or poorly nourished, that can affect your energy, and that makes it harder to overcome the obstacles in motivation. Pace yourself and allow for breaks. It's very easy to fall into a trap of feeling defeated because maybe you used to mow the whole lawn and now that just is so exhausting you can't think about it. Well, what if you only did it in pieces, or what if you split it up into more times? Maybe you don't have to clean your whole house in one day, but maybe you do one room or half a room. So kind of pacing yourself and recognizing that what's the right amount of activity today is not the same as what it was 2 years ago. So you have to make adjustments to keep up with your current level of abilities. Finally, think about what you used to enjoy doing and what made you feel enlivened, and try to incorporate those activities or parts of them to encourage you. So if you're someone who always enjoyed dancing or music, maybe you can find a dance group or a group that uses music to support movement. If you were never a dancer, you're not going to start ballet, most likely. You might decide that boxing is for you, or cycling. So it's not one size fits all. And I always say that the best activity is the one you're going to keep doing. So you can help adjust your choices and activities to make it easier to be motivated. So number 7 non-motor symptom is depression. So depression is actually a biological part of Parkinson's and not only a reaction to Parkinson's. So you might think, well, sure, it's depressing if you have a health condition that affects what you're able to do. But in fact, it doesn't only have to do with how bad is your Parkinson's. Depression is a symptom of Parkinson's, and so is anxiety. That can be, even if your Parkinson's is super mild, even before your Parkinson's has enough symptoms to really catch your attention. It turns out that about 1 in 3 people with Parkinson's at least will have clinically significant depression at some point. And studies have shown that depression is more influential on quality of life than even things like tremor, falls, and other really obvious things. So it's very important to identify it and manage it when it's present. So these are some tips to recognize depression in yourself or in the person that you love. Some of the symptoms are sadness. That one may be the most obvious. Feeling hopeless, like not able to see the positive aspects of the future. Noticing changes in your appetite or sleep, and sometimes those can be more and sometimes they can be less. Sleeping all day long or not able to sleep. Losing interest or enjoyment, not being able to enjoy things that you normally find enjoyable. Feeling guilty or worthless. Being more irritable than normal, problems with concentration. In fact, there's a term called pseudo-dementia, which means when people are very depressed, they can have such a hard time concentrating, it can mimic signs of a memory disorder, and that's what we call pseudo-dementia. Treating depression can help. And of course, recurrent thoughts of death or suicide. The tricky thing is some of these symptoms can overlap with symptoms of Parkinson's, like fatigue and apathy, that don't necessarily mean a person is depressed. But if a person experiences multiple symptoms here, we should definitely discuss it. So how do we manage depression? The first thing is to rule out a metabolic problem, like maybe a low thyroid that can cause a low energy level or change in appetite or sleep. The other thing is make sure you're getting enough rest and getting physical activity. Physical exercise promotes endorphins and body chemicals that make us feel good, and so that's very important. And critical is social support. Sometimes social support can be a church or religious organization. Sometimes it's your friends. Sometimes it's your family. And sometimes it's Parkinson's support groups. But it's very important to have people to lean on that you can rely on. There are treatments. The first is we want to make sure your Parkinson's is under the best control it can be under. There is therapy for depression. And there are medications. So in Parkinson's, you hear a lot about dopamine, and low dopamine is behind a lot of the movement symptoms. But in fact, it's not only a dopamine problem. Low serotonin is the reason that people experience depression and anxiety. And the medications that help depression enhance serotonin in the body. Those medicines can take 4 to 6 weeks to kick in, sometimes less, sometimes more. So it's very important not to give up very quickly if you don't feel better immediately. It's also important to recognize that we have a whole bunch of options, and the first one may not be the right one. So don't be discouraged if the first one doesn't give you the full benefit. These medicines fall into the categories listed here: selective serotonin reuptake inhibitors, selective serotonin norepinephrine reuptake inhibitors. So the difference is the first ones lift up serotonin. The second ones also lift up norepinephrine, another neurotransmitter. There's a class called tricyclic antidepressants and monoamine oxidase inhibitors. It's not super important for you to remember the categories. It's more important for you to know that there are lots of options available that can be helpful. Severe cases may need things other than medicine, like additional therapies like transcranial magnetic stimulation or very rarely electroconvulsive therapy, but usually medicine and sometimes therapy can also do the job. So the next symptom is cognitive changes or memory and thinking changes. And this cartoon is someone erasing a person's brain. And sometimes you feel like somebody must have gotten up in there and erased some of the memories or the thoughts, or maybe your spouse might wonder if somebody got up in there and erased a conversation you had. Cognitive symptoms in Parkinson's can range from nothing that really is impactful to having really severe memory troubles. It's not the same as other cognitive disorders. It's different. Mild cognitive impairment is memory or thinking changes that don't cause major changes to daily function. So that might be where we've all forgotten where we left the keys, or maybe we can't think of a word we want to say. With or without Parkinson's, many of us have experienced that. Dementia is a word that refers to severe memory changes that impact daily function. So what are the types of symptoms we see in Parkinson-related cognitive changes? The most common is slowness of thought, or we call that bradiphrenia, which is where it feels like the gears aren't just turning as fast and it takes a little longer to get to your thoughts. Being forgetful or memory impairment, word finding difficulties, what we call the tip of the tongue problem, where the word is right there and you know you can almost think of the word or the name or the thing you're trying to say, but you just can't bring it out. Trouble multitasking or doing multiple things at once. So you may find you used to be a manager, or maybe you were spinning 10 plates at once, and now you might recognize you need to take one thing at a time and focus on it. We call executive dysfunction the problem of managing and planning and executing tasks in an organized way. And visuospatial processing. So that can be interpreting maps or where things are in the environment. So those are the most common areas affected. So what are the tips for managing cognitive changes? One of them is be sure that if there is depression, that's treated. Be sure you get good rest and check the medication list. And we're not only talking about the Parkinson medicines. There are very common medicines that are used in people of all ages, but especially as we get older, especially bladder medications, pain medications, and sleeping pills that can cause a lot of cognitive and thinking problems. So some of the medicines that help control the bladder urgency can cause confusion or memory problems. And so it's very important to have your doctor check your list and see if any of them could be culprits. And if they are, can you do without them, or can you maybe be on a lower dose? So those are important. The next one is if a change is sudden, make sure there's not an infection. It's really remarkable how many times an infection like a urinary tract infection or a new health condition can aggravate the symptoms of Parkinson's, including the memory. Finally, we have to review the Parkinson-related medicines, because some of the ones we use in Parkinson's, including amantadine, dopamine agonists like pramipexole or ropinirole, also known as Mirapex and Requip, or Nupro, also known as rotigotine, some of those can cause confusion. And they may be something you took for many years and it didn't bother you a bit, but as you get older, particularly as Parkinson's changes and other medicines may change, they can bring about cognitive changes when they didn't used to. So Even if you think I've been on that forever, it can't be bothering me, don't rule that out and have your doc take a look. There are medicines that can actually help cognition. And so when all those other things have been ruled out, there are medicines that can support memory. Now, they're not miracle drugs, so they don't necessarily totally overcome memory changes, but for some people, they can give a boost. And there are 4 of these, and they can be tried. 3 of them work a similar way, and the last one works differently, and they work on acetylcholine or glutamate, different neurotransmitters that are not dopamine. Finally, exercise is one of the things that we believe may slow down the progression of mild cognitive changes to be more significant. So in the way that you're able to safely, and maybe with the guidance of a physical therapist, physical exercise actually supports your brain health, not only your body health. Parkinson-related psychosis refers to experiences where you may see or experience or believe things that may be out of line with reality. And this doesn't happen to every person, but let's talk about it. A hallucination is a sensory experience like seeing something that's not really there. And it could be like feeling as if a shadow went by, or it could be as if you thought you saw a person. It could be misinterpreting objects like some socks on the floor looking like a mouse or an animal. And those things can be mild and not really troublesome, where you know it's your eyes playing tricks on you, or they can be more significant and bothersome. Paranoia is being suspicious unnecessarily, and sometimes that could be feeling like someone's trying to trick you, or maybe feeling like your spouse or significant other is not being honest with you, and we call that paranoia when it's not in line with reality. These can be side effects of medications, or it can occur in Parkinson's just because of Parkinson's. Sometimes we can adjust medications to control them, and there are medicines that can be very effective at treating these symptoms if they are bothersome and impacting your wellness and your quality of life. If a change is sudden, like suddenly hallucinating, then we would worry that there could be an infection or something else, maybe a change in kidney function or something different that may need some workup by a physician. So the tips to manage psychosis are that, first of all, if it's sudden, rule out other causes. If a new medicine has been recently started, it may need to be discontinued. Ask your doctor to review both your Parkinson and non-Parkinson medicine for any contributors. And be sure you get sleep. Sleep deprivation has been known to cause hallucinations even in people who don't have Parkinson's if it's severe. Be aware that there are medicines that control hallucinations. Now, some of them can aggravate Parkinson's, but some of them can be used safely. So some of the medicines listed here, quetiapine, pimavanserin, and clozapine, and in some cases rivastigmine, are examples of medications that can reduce hallucinations and paranoia. They can keep people healthy and well and getting good rest. There are some side effects that have to be considered. And so whichever one you and your doctor decide on, you want to discuss the pros and cons ahead of time and monitor for side effects. So you keep hearing me mention sleep. Sleep is really important in Parkinson's, and ironically, it's also really commonly impaired in Parkinson's. So the things that can affect sleep include medicines wearing off. So sometimes people wake up with cramps in their legs or feeling stiff or shaky because of their medicine wearing off. And that can be related to things that change in Parkinson's requiring adjustments in the medication. Anxiety can interfere with sleep. Sometimes you can't turn your brain off. Restless leg syndrome is a condition where your legs or feet or even other parts of you could feel really uncomfortable, agitated, like ants in your pants, and you just have to move. And so that's a condition that's also medically manageable. REM, sleep behavior disorder, is a condition that's very common in Parkinson's, where when you're dreaming, your muscles aren't paralyzed as they're supposed to be during dreaming sleep. And so you can kick and move and punch and roll out of bed. And when that disrupts sleep, there are treatments available. Dr. Deeb mentioned urinary issues. So waking up all night to urinate makes it real hard to stay soundly asleep. And there are other sleep disorders that can be more common in Parkinson's, like sleep apnea. And so you may need a sleep study to be sure there's not something else going on. A few tips for managing sleep. One is dimming the lights an hour before bedtime. When the lights are dim, our brain releases something called melatonin that signals our body and brain it's time to slow down. This is how animals and humans have circadian rhythms, meaning we know that daytime is our most active time and nighttime is naturally our most restful time. Dimming the lights before bedtime helps signal your brain it's time to get tired. Avoid very stimulating activity 1 hour before bedtime. Have a quiet, comfortable room, adjusting the temperature and other things as you need to. We joke that the bed should be used for 2 things, one of them being sleep, and that other things like reading or playing video games should probably be done outside of the bed if it's interfering with your sleep. Avoid caffeine after lunchtime, and avoid bright screens at bedtime. I won't be as strict as our sleep specialist would be to say you should never read in bed or never use a screen in bed. I might be a hypocrite. Some of us look at our phone a few minutes and maybe we feel like it helps us settle. If you insist that that's true, at least dim the lights. There are settings you can change that can make your screen not be so bright that it suppresses melatonin and makes you get awake. A few other tips: avoid long naps. Now, when you're super tired and when you're worn down, sometimes we'll encourage you to take a nap because it can recharge your batteries, but you want to keep those brief or else they can reset your sleep clock so that you don't get tired at bedtime. We always want you to do exercise, but if you can, avoid doing it the hour before bedtime because for some people that activates you and gives you energy. If you're in bed a long time and not able to sleep, it's recommended that you actually get out of bed and go back when you're tired again so that you associate bed with sleepiness. You also want to have a regular sleep schedule in terms of your wake up and go to bed time so that your brain can adapt to that. There are therapists whose whole practice is devoted to sleep. We call those cognitive behavioral therapists for sleep therapists, and they can help you additionally. So we talked about dimming the lights. We talked about a lot of these things. Sorry, went the wrong direction. And that's what we have for you in terms of the top 10 non-motor symptoms. We saved a little bit of time.
Yeah, that's great.
If anybody has a few pressing questions, we may be able
maybe we'll just unshare the screen so we can see your
okay.
and everyone else. Well, that was really amazing. I think what we realized just looking at those slides is how important non-motor issues are and probably how much time we all our patients are suffering with those central issues that really affect their quality of life. And then also how many things that, we as doctors can really, try to help with. And so I think it's really great that you highlighted all of these individually, and it took, quite a long time to go through all of them. So, because there are, each section is so dense. And I think on this video series, if people want to go back and refer, we have all of these will be on YouTube, and we have individual talks, I think, on all of those topics. But I think you gave some very practical tips. Some of the talks were a little bit more about the esoteric science behind them. So I think this was a great review. So I really appreciate that. There's some congratulations to you about how clear the presentations were and stuff. A couple of questions came up in the chat. One was about hot tubs and bath. Getting out of the hot tub or bath causes dizziness. Maybe you want to address that, Irene, because I think, or I can't remember, was it Wissam?
I think that was Wissam, but maybe we can both throw out a comment on it.
Wissam, if that was your topic.
Yeah, you want to go ahead with some?
Yep.
Okay.
So going out of a hot, so it's mainly the heat of the tub that will cause the low blood pressure because when your skin is hot or your body is hot, your body is going to do something called vasodilation. Your skin is going to try to release some of that heat out by getting the blood to go out of the large arteries into the smaller ones, and then effectively redistributing the blood, and then effectively having less blood available in the big arteries, and then dropping your blood pressure. That's why you might feel more dizzy on a hot day compared to a cold day. So it's important for people who have low blood pressure to avoid hot tub exposure because that can make them pass out or exacerbate their symptoms.
And if you really super enjoy it and you don't want to avoid it, then at least hydrate. If you can drink, like Dr. Deeb said, that glass of water, if you drink an extra glass of water so that there's more fluid in the tank, sometimes that can overcome it. The other thing is before you emerge, squeeze your knees to your chest a few times or squeeze your tummy as if you were straining for a bowel movement. And some of those maneuvers might help avoid the drop when you stand up. Getting yourself circulated, squeeze your knees, and be hydrated. Those would be some good pointers.
Great. Yeah, I mean, I have patients that I think should avoid the hot tub altogether because they're so sensitive even outside of the hot tub. I think if you enjoy the hot tub affairs, put your feet in, enjoy, you know, a glass of lemonade or water on the side, you can still sort of participate in the peri hot tub activities, but hot tubs can be quite dangerous for some of our patients. So I agree. Okay, well, there's a couple of other questions. So one was about brain exercises and cognition. Maybe Irene, you can take that one.
Yeah, so it's tricky because a lot of it we don't really know the full answers, but it appears that there is an expression, use it or lose it. And I do think there's a lot of truth there, that if you don't engage your brain in activity, and we do think that learning new activities may help release dopamine, and that those are good things. There is a little bit of context dependence. So if you only do crossword puzzles, then you may just get really good at crossword puzzles. And it may or may not help you remember people's names and so forth. So I think it's important. It's very important to use your brain. And I always promote being cognitively active, socially active, and physically active. And I think all of those go into brain health. So it is good to do cognitive exercise. And it's good to do different kinds of it. So keep it active. We don't know one particular brain exercise that's better than others or more useful than others at this time. And probably the best evidence would be for physical aerobic exercise as helping cognition.
Absolutely. So one other maybe question we'll take, and then we unfortunately are kind of out of time. We'll have to have you guys back for another session just to answer questions. So one was about dopamine agonist side effects, you know, that affect cognition. Are they reversible after the medication is discontinued?
That is such a good question. Thank you so much for asking that. It's so important. Yes. So in short, the part of the cognition that's from the medicine will go away when you stop it. So we don't believe that taking those medications hurts your memory down the road. We just believe that they can give you side effects. So they can cause hallucinations, confusion, and other things. But when you discontinue that medicine, they have to be weaned. Don't go home and go, oh my gosh, I'm on this. What if it's the cause, and stop it suddenly? Because you can actually have a withdrawal syndrome where you feel restless and agitated and uncomfortable. So they have to be weaned, but the components due to the medicine are reversible.
Great. There's just one about controlling spending in someone who sounds like it's a caregiver talking about a patient. I think we won't have a lot of time to get into that, but I think that's a really important issue. It should definitely be brought up with your neurologist, and that can be directly linked to medication. So if you're having someone in the family spending a lot of money and you're worried about it, talk to your neurologist about it. That can be dealt with, but requires, you know, working closely with your neurologist. So, so I think this was a great session. Maybe I'll give you a minute each to give us some inspiration for our patients out there. We like to end with, you know, a hopeful sort of inspirational kind of, you know, quote from each of you. So let us know. Maybe we'll start with Wissam and then end with Irene.
Yeah, so I think like when we usually make a discussion where like list all these problems, I think it is always important to keep in mind that there's a lot of things we can do for a lot of those symptoms, and we're learning every day a lot. And research in terms of Parkinson's symptoms, both motor and non-motor symptoms, is exploding effectively. And then we're really understanding more and then looking at the person as more of a general person and focusing on their own needs and trying to improve their quality of life. So even though this might be like, oh my God, all these symptoms I have to deal with, I think it's good to keep it in perspective that there's a lot of stuff we can do, and then hopefully in the near future have much more stuff that we can help people with.
Irene?
Yeah, I would say that, you know, Parkinson's affects how you do things, but you can live well with Parkinson's. So there's a lot we can manage. You have to keep enjoying what you enjoy and being who you are and working closely with your healthcare team. It's a moving target, so the management strategies adjust with time. So it's important you have a good healthcare team and just stay active and keep doing the things you love. I think that's the most important thing.
Great. Well, I think this was a very educational session. I had a lot of compliments in the chat. One person actually wrote that they didn't realize that all of these things had to do with the Parkinson's. They are just making that link now watching this talk. So I think you get empowered by being educated and understanding, you know, what all the disease has, you know, mixed into it. It's not just the tremor, not just the stiffness or slowness. And I think we as teams, like you said, have to approach this in a more holistic way to understand what really makes a difference for our patients and their quality of life. So I couldn't agree with you more. One other thing about the social connection, something that I'm spending so much time talking about, we actually have an abstract that is being highlighting that at the Movement Disorders meeting, talking about loneliness and social connection. And it's also Suicide Awareness Month. So I think we just need to, you know, think about all of our fellow human beings and people we love on this planet. Reach out to someone today, make a phone call if you know of somebody who's lonely, and hopefully we can all keep connected in this physically distanced world. So thanks so much, PMD Alliance, for continuing to host this. I appreciate it. I appreciate you guys taking the time out of your busy clinic schedules to join us. And I will pass it back to you, Rebecca.
Wonderful. Well, thank you so much. This was probably one of my favorite presentations that we've had. So thank you both for joining us. I did want to put in the chat once more where you can get the book on Amazon. They're living, what is it? Sorry, Living with Parkinson's Disease. I saw Living Parkinson's and I was like, wait, isn't there a with in between that? So please get the book if you haven't read it yet. We did do, while we were all listening, we did do a quick drawing for one lucky viewer to get the book that we will be sending. So that is actually going to Lenore Freeman. So Lenore, we will be sending you the book after this program. And I hope you all enjoyed. If we could turn on our cameras for those who are waiting around for our PMD Alliance wave, because I know that's one of my favorite parts. We're gonna just wave and say goodbye. Thank you for joining us.
Thank you.
Thank
See you
you.
all next time.
Thank you, everyone.
Bye.
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 Thank you, guys.